Hey NPs, we know how hard it can be with your busy schedules to stay up to date in your clinical practice and earn your required CE and RX credits. The Nurse Practitioner Podcast is here to help. This fall, join us for the latest installment of Lippincot's National Conference for Nurse Practitioners, a fully virtual event that offers the most convenient, flexible way to learn and earn credit. Here's how NCNP works. The conference runs live from October 23rd to the 25th. If you're free, join to watch sessions in real time, ask speakers questions, and network with your peers on the event's new and improved virtual platform. Not free? No worries. NCNP On Demand provides access to recorded sessions for 90 days after the live event to allow you ample time to watch and earn credit. Listen from home or on the go, whenever and wherever you can fit talks into your schedule to earn up to 49 CE and 33.5 advanced pharmacology credits. No matter your specialty or setting, NCNP's 30-plus sessions delivered by expert speakers have you covered. Talks tackle clinical guideline updates, best practice advancements, professional development trends, and more across all areas of practice. To learn more and register, visit tnpj.com and click the NCNP tab at the top. Use promo code PODCAST25 at checkout to receive 25% off the registration fee. In this episode of the Nurse Practitioner Podcast, Dr. Kerry A. Milner and Dr. Ellen Fineout-Overholt discuss how to be successful with the DNP project as part of this terminal degree, Part 1. Common questions students have related to problem identification, project mentor, and evidence review for the DNP project. The series is structured into 4 episodes. This first episode, Getting Started, covers foundational steps like finding a clinical problem, selecting a mentor, and conducting an evidence search. Whether new to the DNP program or deep into a project, this series offers the support and knowledge needed to navigate the journey confidently. How do DNP students identify a clinical problem?
To identify a clinical problem, you should engage in clinical inquiry, step 0 of the EBP process. And this involves questioning the status quo, discussing with your peers or mentors, and reviewing data, also known as internal evidence, to identify potential problems in the clinical setting. Clinical problems require urgent attention due to its actual or potential impact on patient safety, care, or the health systems. Examples of clinical problems include increased rates of hospital-acquired infections or patient falls causing harm that surpass national benchmarks. A clinical problem currently facing all acute care settings in the U.S. right now that began in July of 2024 is the shortage of blood culture bottles and the impact on blood culture contamination rates, patient care, and safety this is causing. Per the CDC, until the blood culture bottle shortage is resolved, health systems are to draw one set rather than the established 2 sets. Blood culture contamination rates have spiked among healthcare systems because of this, and this is an important clinical problem that is widespread that students can use for a DNP project.
Thanks for explaining the identification process. Where do DNP students find internal evidence to describe the clinical problem?
There are several valuable sources of information you can tap into for internal evidence. The first is the electronic health record. These are a treasure trove of data, including patient demographics, medical histories, lab results, treatment plans. And the DNP student can analyze these electronic health records to uncover trends or pinpoint specific problems or gaps in patient care. They can identify safety issues. There's also clinical databases. Many healthcare organizations maintain databases that track specific patient populations or clinical issues, like hospital-acquired infections, and the DNP student could compare the data that's in either their unit, their department, their hospital, to similar institutions, and this can provide valuable insights into where they are for this particular clinical problem. There's also healthcare system specialists and teams. These are your quality improvement, infection prevention, and performance improvement teams. They regularly collect and analyze data related to clinical problems and patient outcomes. Their expertise can be invaluable to the DNP student to try to understand and address specific issues in that particular setting. There's also national and international databases. So nationally, we have the Agency for Healthcare Research and Quality, and internationally, we have the World Health Organization, and both these entities offer extensive data sets on patient and system outcomes. And the DNP student can use this data to help them frame and describe a clinical problem more comprehensively. There's also professional organizations or local health departments. And these can help because, for instance, specialty nursing organizations may have data on particular clinical problems that are important to them. Public health departments could be they do track certain things, and you can use either the organization or the public health department to identify benchmarks, and you can then compare it to the same benchmark in your particular setting. So just to be detailed oriented, to find specific internal evidence, you want to follow some steps. And the first thing for DNP students is to get approval from the right person or persons to pursue the clinical problem and access the data, or use quality improvement methods to collect their own data. Very, very important step, because DNP students often work as employees in these institutions, and they should not be accessing data for their project unless they have permission. And these permissions can take the form in some health systems as a formal process that the students have to follow. This type of approval that I'm talking about is different from the final project proposal approval that may entail an ethical review of the project by an IRB or health systems committee that reviews the project to determine that they are HIPAA compliant and not research. So just, note there are two different approvals. This is just the initial. So after you gain health system approval, to access your organization's data sources like the EHR, the electronic health record, or a clinical database, you can then look for data on your clinical problem. I highly suggest that DNP students should engage with the quality improvement teams, the infection preventionists, or performance improvement specialists so that they can understand the data that's collected. They'll also probably be able to help with more efficient searches for data on the specific clinical problems. There's also in many health systems dashboards that report data. They could be minute-by-minute data, or it could be weekly. Data is also discussed in huddles. And so these are great for identifying trends or patterns or benchmarks for a particular clinical problem. The last suggestion is connecting with those professional nursing organizations or local health departments so that you can get some comparative data if your clinical problem directs you that way. And then I would just like to say that for more detailed guidance on clinical problem identification and internal evidence, please check out our Article 2 in our AJN series on clinical inquiry and problem identification. It covers these topics that I just talked about.
We appreciate you sharing these insights for our DNP students listening. When are DNP students ready to draft a clinical question, and why do they need to use a particular format/method?
Great question. When we think about what Kerry has just shared about the clinical problem and the internal evidence, that's your first indicator of being ready to draft a question, is when you have a complete understanding of the clinical problem from the internal evidence. So if you're still wondering about things, don't really know how things are working out in your organization, haven't collected data, don't have baseline data to say this is what the clinical problem looks like, then you're probably not quite ready to draft a clinical question. You also need to know the context of the clinical problem, the political context, the fiscal context, the feasibility of managing or mitigating issues that are influencing the problem. This takes some time to understand and know. A lot of times we have students who want to dive right into and ask a clinical question, and then later they find out that's not exactly the question I really wanted to ask. So doing this pre-work to understand the clinical data that are really telling you what the problem is and the context around that is really helpful before you ask the question in a particular format, which we'll talk about. Also, considering when you're asking the clinical question, what does it take to understand what we already know out there? So doing an exploratory search to just understand what's being published about the clinical problem that you now know about and are asking, beginning to have inquiry in your mind about is critical to this process. The fourth thing that I would say is Once you've done this exploratory search, you have the data that's describing the problem, you know the context, so you pretty much have a good, well-rounded look at this clinical problem. Then you start to go, what can change the outcome that I'm asking about, the clinical problem is based upon? Clinical problems are, as Kerry alluded to, they're about when things are harmful. We have an outcome that's not good. So we want to understand, how can we change that outcome? So once you've learned about the clinical problem itself, the data, the context, and what we kind of see out there published, we can then begin to say, this is what I start to see published out there that may influence this problem enough that we can change that outcome. And so that's when you go, I know now what I want to ask about, and I know what my current practice is. And then that begins us on that pathway of, why do we need a particular format? Remember that the clinical question is to describe the clinical problem so we can get an answer from the literature. That's the entire reason why we ask a clinical question at this point in this process. So putting that into a format helps us define what we want from the literature in an efficient, searchable way, so we can get a quick return on that search. So we aren't searching for hours on end and still going, I still don't know what's out there. I still don't know how to answer my question. So we use a particular method called the PICO method, P-I-C-O with a T on the end method. And the reason we use that is so that we can understand what the population is we want to apply the evidence to once we learn about it, identify clearly what is the intervention or issue we're most interested in understanding from the literature that's going to help us know what works, what the comparison is or the current practice, and describe that so we understand when we look at studies, we'd like to gather studies that are going to be the thing we want to know if it works or not, because we've sort of seen it in the literature. We think that's a good option for us from a political, fiscal, feasibility point of view when we look at our problem. And then we want to understand that in those studies, they should also have the comparison or the thing that we currently do so we can see what actually is working and how our own practice is now being evaluated compared to what we think might work better to mitigate our problem. The outcome is always, of course, clearly written and should be in the clinical question as the first thing you probably define and write. And it should always be the first thing you go to search, because studies should include that clinical outcome that you want to see changed. And then the last part of that methodology that we use to construct this question is the time it takes for the intervention or issue to be resolved and the outcome to happen. And so the reason we ask that is because often researchers may do a cross-sectional study, or they may have a cohort study, but they didn't follow them quite long enough to establish that the intervention did indeed bring about the outcome. So those are things to consider as you're thinking about when are you ready to ask the clinical question, how do you ask the clinical question, and why do you ask it in that particular format so that you can go and search the literature.
Adding to that last question, how do DNP students use the clinical question to guide the search for evidence? Do they need to limit searching years?
Oh, that's such a powerful question. As we think about the answer to the first question is absolutely yes. You do use the clinical question to guide your search. It is your searching framework across all databases. So the systematic search tells us that we're going to approach how we search across all databases the exact same way. How do we know what that way will be? It's by our clinical question in that format we just described. So when you think about the first thing that you do is you enter, if you will, the O into your search strategy, the outcome into your search strategy, and then you're going to be thinking about what are the synonyms. I know I didn't call it everything that it might be called. I look at synonyms for that term, but that term that we put in our clinical question guides us about what synonyms we need to think about. Same is true for the intervention, same is true for the current practice that is a comparison, and the same is true for a population. So the answer is absolutely we do use it, and we use it as a framework to guide how we approach our systematic search. And there is a methodology that is outlined in our AJN series that helps you go step by step to really get to the relevant evidence quicker so that you're not searching for days on end or even hours on end. Now, the question about do I limit my searching years is a powerful one. In the literature and in school, we often hear search the last 5 years. In fact, I know even journals sometimes say where we won't accept references that are over 5 years old. The question comes to us about why we put an arbitrary rule around searching the time frame to search. And it really isn't helping us if we put an arbitrary rule. However, it does help us tremendously when we think about, do we see a plethora of information being published about a particular thing, and it was published 7, 8 years ago, and now we have a trickle that's coming in, but we don't have a lot. If we search with our arbitrary rule of every 5 years, we will think there's not much evidence out there to guide our practice. But if we don't limit it at all, and then search, and then start to see, oh, wow, the pocket of gems that we need to see was published about 7, 8 years ago, and we do have corroborating evidence that's been published since. That's great, but we can now go, well, we probably don't need to search for anything over 10 years because we know we're not going to have a lot of information there. So I would caution folks from making an arbitrary rule, but make a reasoned rule, a reasoned for why you're going to limit in searching the number of years. Because if you just put an arbitrary rule, we're going to end up getting what we don't want, which is a false information. But if we do it wisely, it will benefit us greatly.
Thanks for sharing this valuable information on how DNP students can refine their search. How many articles do DNP students need in the evaluation table?
Again, a wonderful question, and one that students ask all the time. At the DNP level of education, this is our doctorally prepared clinical experts. They need to have the full body of evidence in their evaluation table. That means all that we know about a particular topic. Why is that important at the DNP level? Because you are the person who's saying that this is the foundation on which I am recommending practice changes. Now, recommendations aren't things we can take or leave, right? We need to be able to say, this is best practice. Therefore, you should be doing it, right? So as we think about how many articles do you need, what's in the evidence, what's out there in the literature, how do you know that you search systematically across several databases to know that you've pulled everything that you can pull, and you'll start to see saturation, you'll start to see duplicates, you'll start to see, okay, I think I've searched my database is thoroughly enough that I know that I have everything out there. And then you start to look at relevant information that's going to answer your clinical question. Another reason why that clinical question is so important to drive that intersection, if you will, with the existing literature. We start to look at those things, and so there is no firm answer for how many articles you need to have in the evaluation table. You need to have enough to understand what we know about this particular issue that's in your clinical question and answer it as thoroughly as possible.
Next, how do DNP students create a synthesis table, and how many synthesis tables should they have?
Great question. And I'm building on the wonderful job that Ellen has done describing the clinical question and the evaluation table that is built out of the clinical question and the search. And so after you have that evaluation table in place, next up is creating these synthesis tables. And it's a hard thing to teach, and it's something you have to practice. DNP students have to practice this, and highly, highly recommend that when they do get to this step in the process, that they work closely with their faculty member on this. So the purpose of a synthesis table is to pull together relevant information from the evaluation table in a way that visually shows what is known about a topic or a clinical problem. An evaluation table typically includes columns for study details like authors, year, study design, level of evidence, sample size, setting, variables, outcome, impact, strengths, limitations, key findings or conclusion on how the studies that are entered in this evaluation table connects with the other studies and sources within it. The process of synthesis begins with the student recognizing patterns within the data or information as they enter it into the evaluation table. We also call this evaluation table the body of evidence, so you'll hear me use that term quite often. Also in our AJN series, you'll see it. So DNP students should be noting trends, patterns, caveats occurring across studies within their body of evidence, and they may want to bold this information to signal possible later use in a synthesis table. So the first type of synthesis table that should be in all DNP projects is a level of evidence synthesis. This information is easily pulled from the evaluation table because your evaluation table should have a column labeled level of evidence. And students, for creating this table, students can list the studies or sources horizontally across the top of the table, starting with the number 1. And that links to their evaluation table. So number 1 should be the same study or source in each. And this is also the highest level of evidence. And then what happens is the organization in the evaluation table goes highest level of evidence to lowest level of evidence. And so that's mirrored in this synthesis table of level of evidence. And you go from high to low. So it creates a great visual representation of level of evidence. And what is level of evidence? That is the study design. And study design can equate with, going from systematic review, meta-analysis of randomized controlled trials, being the highest level of evidence, all the way down to a lowest level of evidence would be something like expert opinion. So another type of synthesis table is an outcome synthesis table. And for this type of synthesis, DNP students should look across all studies or sources to identify things like reoccurring interventions or associated outcomes. And I'm going to go back to my blood culture example, the blood culture bottle shortage clinical problem. And if the DNP student was to craft the evaluation table for this, from our studies that are included in there, they may see recurrent strategies used to impact blood culture contamination in these different studies. And these interventions or strategies might be blood culture collection kits. It could be diversion devices. It might be a dedicated team to draw the blood culture. And in their evaluation table, the students should bold these strategies. So then they'll easily see when they go to create the synthesis tables on these interventions and visually display their impact on blood culture contamination rates. So the next question is, how many synthesis tables should I have? So moving right into that. So this is another sticky one that you get asked. So at minimum, you should have the level of evidence, and you should really have one more. However, you could have more, and it's going to depend on your body of evidence. So please take a look at Article 5 in our AJN series that will be published in early 2025. Erin, our DNP student, crafted an evaluation table for a body of evidence that answered the clinical question: in mechanically vented adult patients, how does early risk stratification compare to no risk stratification affect days on ventilator and infection rates during ICU stay? And Erin noticed patterns emerging across the studies that helped identify age, duration of mechanical ventilation, severity of illness scores, sputum culture, and oral hygiene as commonly occurring risk factors for ventilator-associated pneumonia. She bolded these terms in the final column of the evaluation table to help her readily see the patterns across studies. Her first synthesis table was a level of evidence that she pulled from her level of evidence column in the evaluation table. Her second synthesis table was an outcome synthesis table of ventilator-associated pneumonia, mechanical ventilation duration, length of stay, and death as her outcomes. And her third synthesis table was risk factors predicting ventilator-associated pneumonia. And she had risk factors bolded in her evaluation table, so it came in really handy that she could quickly look back at that and pull it into her synthesis table. So please go take a look at that Article 5, because having the article in front of you as you listen to this podcast will probably really help with understanding what we're talking about today.
Finally, What qualities should DNP students be looking for in a project mentor in the clinical setting? How do they ask someone to be a clinical mentor?
These are great questions because the clinical mentor is the liaison between the faculty advisor and the health system or the clinical setting. So clinical mentors are really important. And this is something that should not be rushed into. It needs to be well thought out by the student. So some of the qualities that students should look for are, first and foremost, is their expertise and experience. The clinical mentor should have substantial clinical experience, preferably in the area related to the student's project. They should be knowledgeable about evidence-based practice, quality improvement, and your specific clinical focus. It's great if the clinical mentor is supportive and approachable, encouraging, willing to offer guidance, open to questions, provides constructive feedback. So you want someone that is going to tell you what you need to hear. They should be interested in your project, and committed to it and wanting to invest the time and effort to help you succeed. They should have strong communication skills because they could be the gateway for you for many things in the institution. And so they need to help you navigate if there's any challenges. They need to be politically connected is ideal and just help the student navigate any challenges that come up. And they come up. That goes along with that they should be well connected within the organization. They should know the resources, how to access the data, the different stakeholders that you need to engage, how to facilitate approvals or support within your organization. You want to look for someone that values professional development and growth in you because the student is the project manager. And they're being a project manager at the same time, there's this tremendous amount of learning that's going on. And so you need a clinical mentor that's going to foster developing those skills and attaining that knowledge. It would be nice if they had mentored before. That would help. And then the mentor should be familiar with the organization's mission, vision, and values and priorities so that they can quickly tell you, does the clinical problem and the data that you want to access and the clinical problem that you want to pursue, is it in line with organizational priorities? So something else, switching gears to think about is the next question is, how do you ask somebody to be your clinical mentor? In my many years teaching DNP students, I've come across students that are afraid to ask people to be their mentor. And so I think, what I share with them is first, you have to identify them, who meets the criteria that I just talked about. And who do you respect in your organization? Who are the clinicians or leaders that you respect and they have experience related to your project topic? Then request a meeting. It's better to have a meeting than to try to catch them in the hallway, I say to the students, because, catching them in the hallway, they may not remember the conversation because they're very busy. So reach out by email or in person, request a meeting, and clearly state that you would like to discuss the possibility of them serving as your clinical mentor for your DNP project. Then the student needs to prepare for the meeting. They need to have done a background search, and Ellen alluded to that when she was talking about the PICO question, that background search has to be done first. And you should know your clinical problem, be able to support it, and explain to them why you think they would be a good mentor. The next thing is that you need to explain to them what is expected of them in terms of time commitment, the guidance that you need, any goals, and students need to be clear about the DNP program requirements. And in some programs, it may be a formal process where the mentor has to sign an agreement. And then just some other things, just why you think they're going to be a good mentor for you. And then, you want to end with being flexible, open, any feedback they have for you, and whether they decide to be your mentor or not, because most of our students work in these institutions. alongside these people. And then I tell the students that you should follow up after the meeting or the discussion with an email summarizing things, what you discussed, reaffirming your interest in having them as a mentor, and then if they had any additional questions.
Thanks so much for your time today, Kerry and Ellen. We really appreciate it.
Thank you.
For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at the Nurse Practitioner Journal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.